Kia ora, and welcome to everyone that's joined today. It's a fantastic topic and have been following Corina, Gerard, et al., including Debbie Ryan's work around this particular topic. Many of us will know Corina already, Samoan public health physician with a PhD in epidemiology, established researcher, especially around Pacific topics and cardiovascular disease. Gerard is a public health physician as well, infectious disease epidemiologist with a PhD on evaluating public health programs in infectious diseases. So without further ado, we'll hand over to the two of you and just saying thank you for this opportunity, and thank you to everyone that's called in today. Over to you, Corina and Gerard.
Gerard, are you going?
Yes. Good afternoon, everyone. Thank you for the introduction, and I'm going to share my screen. If that works, is it visible? Thank you. I'm going to talk about a few publications with this, and this is one of our publications in 2024, which is called Selective Underrepresentation of Pacific People in Population Estimates Misinformed Policy Making. We did it together with Corina Gray, who's the second speaker, and also I would like to acknowledge Pacific Perspectives and Debbie Ryan, who made this work possible. Outline of my talk is population estimates. First, I'm going to talk a little bit into detail about the census method and outcome of Census 2018. Then I look briefly in the Census 23 and the transition towards 2028, and I conclude with some conclusions and recommendations. The basis of our population data is the census, and you probably all know how that works. Census has two forms, either on paper or electronically. And there's an individual form, and every citizen has to fill out an individual form with these questions. There's also a dwelling form that collects data on dwellings and which people live there. An important difference is then the individual form is the only form that collects ethnicity in a standardized manner. And the dwelling forms do ask details about persons, but does not include ethnicity in it. These are the definitions of Stats New Zealand, how we express and combine our population statistics, the building blocks. And in blue, we see the census results, which is the total residents in the area and residents elsewhere in New Zealand. And it is called the census, usually a resident population. After each census, there is a post-enumeration survey, which is roughly a door-knocking exercise where people are asked whether they have participated in census or not. And based on that information, we estimate a percentage undercount, and the data is then corrected for undercount to get a better estimate of the population. Then populations are planned forward. The estimate resident population each 3 months, every quarter. Stats New Zealand publishes new estimates for population data, and they update it based on data of residents temporary overseas on census night, and also birth, deaths, and net migration since census night. 2028 was a particularly not very successful census because of the response rates, which you probably all know from the news. And Stats New Zealand, because the data were so poor, decided to ad hoc impute data from admin data, which you see here in red. And what was decided to add residents missing in census response who have been active in tax, health, education, and ACC in the past 2 years. And these are the numbers of the census data collected in 2020-18. This is by ethnic groups, and I want to talk you through the Pacific group, which is highlighted in red. Here in the top, we see that 259 Pacific people have responded to an individual form. We also see that compared to 2023, the response rate dropped by 23%, which was the largest drop of all ethnic groups. This also means that all the other data is not collected in a standardized way for Pacific people, which is household forms that have no ethnicity on it, the admin enumerations, are also imputed, and data is not collected in a standardized way. We then came to a census usual resident population of 382,000 people before the post-enumeration survey was done. And based on the PES results, we estimated that 5% of the population was, Pacific population was not included. And there we get the estimated resident population of 400,000 Pacific people in the country on census night. Later on, when COVID was rolled out, we collected a lot of COVID vaccination data, and then it was found that 45,000 Pacific people were not counted in any of our administration data or census data. And this is also a big sign that there is a large Pacific population that is not counted in our statistics, and I'll come back to that later. The post-enumeration survey also looks at differences in undercount by geographic area. And it is consistent the case that the most deprived populations do participate least in census. And here we see highlighted the dark part in Counties Manukau area, where the undercount was largest. And this is also the part where the most deprived Pacific populations live. There is an extra part of the own population statistics, which is the projected resident population. And this is the same as the estimate resident population, but then based on assumptions about the future, on death rates, birth rates, and net migration. It is estimated how the population is developing in the future. This is designed for planning, and it's updated every 2 to 3 years by incorporating new available information, and it is published annually. Stats New Zealand publishes data by different areas than health, because DHB areas are based on health organizations. So since a long time, Ministry of Health and now Poutoko Ora translates these projections into DHB areas. And these data are published on this website tool by Poutoko Ora. And these are made for the development for healthcare planning and funding. And it says in the notes that it is not meant for monitoring health. An disadvantage of this data is that ethnicity is only provided by level 1 prioritized ethnicity, which is particularly detrimental for Pacific populations, because in 2018, 28% of Pacific children under 15 also identify as Maori, and these are only counted as Pacific in our statistics and also in our projections. Question now is, how does census population data relate to health? And this came to light when COVID vaccinations were rolled out. You may recall that the loosening of our restrictive measures was dependent on the vaccination coverage in certain areas. They were set at 90%. And vaccination targets by DHBs were set by DHBs and were also monitored by ethnic groups. And in the beginning, they used the best available population projections to calculate these coverages. And it soon appeared that certain age bands and ethnicities appear to be over 100% coverage. There was a lot of attention for this also in the news and the media. So a solution for that had to be found. And it was then decided ad hoc to use health survey user data as a denominator for COVID coverage instead of the Stats New Zealand data. And health service user data is defined as all the people who are enrolled in primary health care or have used healthcare in the past year. These are not official Stats New Zealand statistics, similar as the best available population data, and they are not officially or regularly published. An advantage of this data is that they are based on actual data collection and not projections in the future, which means they also have NHI records, and they are not projections, which makes it possible to link the numerator to the denominator, and then percentages over 100% are no longer possible. Health survey user data also introduces new biases, because HSU reflects access to care, and data is influenced by individuals' interactions with healthcare services, and certain deprived populations have less access to care, so they're also less represented in this data. Another limitation is the NHI ethnicity data quality. I copied a study here below, like We Still Don't Count, which is a study done by Harris about Māori data in the NHI. And they linked census data collected by individual forms to NHI, and they found a 20% discrepancy between Māori registered in NHI and in census, which means 20% of people who identified as Māori in census were not registered as such in NHI. The same goes for Pacific people, which is also about 20%. That is not published, but that was communicated to be by the Ministry of Health. So both ethnicities, 20%, are not visible in NHI data. We did an early study in 2022 about the effect of these different denominators for different populations on COVID vaccinations. Here you see the pictures of the European other ethnic group, Maori group, and the Pacific group. And what we found changing between these denominators is that the choice of denominator can disproportionately affect the coverage estimates between ethnic groups, potentially leading to overestimates or underestimates in vaccination rates. And what we found remarkably is that with the one denominator, the coverage was overestimated in one group, whereas with the other denominator, it was overestimated in another group. So it has different effects on different populations. The population undercount for Pacific people has long been known and also been published. This is a Poutoko Ora website, which was previously done by Ministry of Health, the access to primary care. And this is calculated by the numbers of people enrolled in a PHO, which is one of our most reliable databases because it's almost real-time updated and also duplications are not possible. And if you look at these percentages here by ethnic group, Maori access is 85%, Pacific 99%, and other 89%. This does have a note underneath it. It says the estimated coverage for a population, until last year it was the Pacific population, they changed that, is sometimes slightly more than 100%, and they give as an explanation the use of the denominator that I just explained. And this undercount has been known and also published in scientific articles for at least 1.5 centuries. So the study questions for our study were, are the difference between BAP and HSU denominators equally distributed throughout the country? And the other one is, what about other health statistics that use these best available population, as most of them do? What I did was I downloaded the best available populations from the website tool, and I put them in an Excel sheet by DHB, previous DHB, and by ethnic group and by gender as well. And I did the same with HSU data. This was published as the denominator for the COVID vaccinations and therefore available. And I deducted those from each other. And what you expect is that in each region, fewer people use healthcare than there are estimated to be in that area, because you can't have it the other way around, that more people use healthcare. What I indicated in red is the areas where more people used healthcare than they were estimated to be in the area. And the right part with all the red is a bit polluted because that is the risk group of all other ethnicities. But if we look at the first 3 ones, then we see that the Pacific population in counties Manukau has a very high overuse of healthcare compared to the number that were in that country I highlighted here. And this is with 12% is the highest in the whole country. I repeated this also for the next year, for 2021, and then it was even higher, the difference between the two, which is an indication, again, that the population is not well counted in that area. This access to primary care data are published each quarter in an Excel, and I extracted all data in one Excel to be able to look at trends in enrollment by ethnic groups. And in these graphs, you see on the left the enrolled population as a percentage of the BAP denominator in counties Manukau. and on the right in the other 19 DHB areas. And it is here plotted by, started with Q1 2019 to Q3 2022. The green is Pacific, the red is Maori, and the blue is the other ethnicities. And looking at this graph, we see a few really big red flags. Of course, the one is that the percentage is over 100%. The dotted line here is 100% line. But also we see that the highest access to primary care is in the most deprived ethnic groups in the country, which is not what you expect. Another one we see is that access to primary care in counties Manukau in the Pacific population is higher than in the rest of the country, which you also don't expect because there is a higher deprived population. And the last red flag is when we replace the denominator like we did with the other studies, then we see that Pacific people have actually the lowest access to primary care. So it's completely the other way around. Another thing we noticed, this is the same line as we just saw in the previous slide for Pacific ethnic groups. We see the decline in the data and some kinks in the curve as well that are quite sudden. And I indicated in red below, there are notes in this graph that each time there is a kink in the curve, the algorithm has changed based upon which they project the population. And the number of people enrolled is quite stable. And those kinks are just changes based on methodology changes in the estimate of the population. So there are no actually declines in enrollments. We did the same for cervical screening, and I only have one slide for this example. This is extracted from the dashboard from Poutoko Ora with screening coverage for cervical screening. I again plotted this for counties Manukau and the other districts, and we see the green line on the left. For years, Pacific people in counties Manukau, women particularly, had the highest screening rates of all populations in New Zealand. The decline since 2016 is quite worrisome. We also see that in other public health delivery graphs that it is declining, which is probably related to access to care. But here in the end, we did a swap with denominators again, and again we see that Pacific people then have the lowest access to cervical screening compared to other groups. The implications, why does it misinform policy? I copied a cabinet letter here to Minister Farrell, which says Pacific people have high rates of enrollment in general practice, August 2023. So this was communicated to cabinet then. There's also a review of breast cancer screening, which says that there is concerns that Pacific peoples are underestimated and the coverage is overestimated, but they don't quantify how much that would be. Then a little jump forward to Census 2023. The post-enumeration survey 2023 has been much delayed. The final data were only available in December last year. And it shows quite optimistically that nearly 99% of the population has been counted. And this is also called the coverage of census. The response rate is a different measure, which is the number of people who respond to the census with filling out a form. And this is plotted by a year for the last 3 censuses. And we do see in 2023, the overall response rate increased by 3% for 82 to 85. And for Pacific people, it increased by 10% to 74, which is still way too late. They also put a warning here about time series data. They should be interpreted with care because there were changes in census or coverage methodology, and there were quite severe changes in methodology. So actually, it is not sound to compare these at all, the trends in this. Also, we have to keep in mind what happened during COVID, that so many people, Pacific people, were found that were not registered anywhere. And this still has not been clarified. So probably there is still a larger population in the country than we know, which also influences these coverage and these response rates because these are used as the denominator for those measures. Looking forward to the plans for Census 2028, it has been decided that census will no longer be the same as it always has been. We're not going to do a national survey anymore. But the idea is that census will be based on an admin data first approach in the future. And this is a publication in the Public Health Communicable Center by Len Cook, our previous government statistician, with some other well-known authors. And they say that the census is the backbone of all population statistics in New Zealand. And without this backbone built on a high-quality census, integrating administrative data with other statistical sources become far more challenging, potentially compromising the reliability of long-term predictions in public policy. So they have concerns about this method for the reliability of census. Also, as specific perspectives, we used the opportunity to submit a consultation response to Stats New Zealand, and this is published on our website. If you're interested, you can find it here. And our major concerns we expressed in here was that the plan to move to an admin census has been there for a long time, has also been communicated to Cabinet more than 10 years ago. And it was based on 2 full reliable censuses to check the quality of the admin data. And this process was derailed because we had 2 failed censuses, so we do not actually know anymore what the gold standard of the population data is. So also the quality checks that were intended did not actually happen. Another concern is that poor standardization of data quality between agencies, which will be the basis of the new census, hinders accurate linkages. And as an example, I refer back to the NHI that has a 20% discrepancy. We don't know this for other agencies, but probably they are also not as reliable as census data. This method also does not address the long-standing undercount issues in Pacific population statistics that still has not been addressed. And it risks, as also the previous authors say, worsening public service access, and it reinforces bias against Pacific and Maori. This is our recommendations in the submission. The need, as also Len Cook and others said, for a reliable population backbone. And it would be possible to build an IT backbone in which we separate the basic population counts, which is the backbone, from other detailed census data that we use. To centralize a minimum demographic data set across all agencies and enable real-time linking between those instead of the retrospective linking that we are doing now in IDI based on algorithms. And that would be much more transparent and also much more reliable for the data. Another advantage, and this is what Corina is going to talk about after my session, is that it can also be used as a backbone, as individual sampling frame for all our current household surveys. And that would be really improving the accuracy, the efficiency, and also better targeting the surveys, which would be very much cost saving. And coming to the end, to my conclusions, Pacific and Maori population data inaccuracies have long been evident, yet they remain inadequately addressed. Unstable methodologies and frequent changes hinder reliable trend analysis, and we also seen that in the census sequences. Census 2018 transition plans to do not address the existing inaccuracies in Pacific population counts. And a real-time population register or census backbone is essential for delivering transparent, consistent, and timely data, and therefore by supporting more equitable health system under the current reforms as well. In the meantime, I think it is important that we report ethnic-specific outcomes clearly, also with the biases and how this influences our health statistics. That's the end of my talk. Thank you for your attention.
Amir, you're on mute.
My apologies. Thank you so much, Gerard, and just a fantastic presentation, and I'm sure everyone listening has enjoyed that. We just have 2 short questions, one short question, and then we'll move on to Corina, and then we can open up the floor to others. The question was, from Iseta Finau, what is the ethnic specific breakdown, Gerard? And I think you mentioned it about us just going to level 1.
Is that about of census
Pacific.
data?
And Pacific populations. She's
Sorry, are we
asking for
talking
level
about
2.
the response rate? Or how
I
the
think
data is
across the presentation, we've
Yeah,
talked
well,
about level 1. Is there
yeah,
any space where we've gone to level 2? Because, as
no,
you know,
and
for populations.
sorry, I understand it now. No, Stats New Zealand in 2018, they wrote an evaluation of their data quality, and their own evaluation is that level 2 data is not of enough quality to report by level 2 data because the collections is not accurate. And I think that is the same in health data. Health data is prioritized not only for statistical reasons, but also because the quality of level 2 data is not complete enough to report by level 2. Yeah.
Okay, Zeta, I hope you got that answer there. There's also one from Megan, and maybe it's a comment. Can you see the comments, Gerard? It's referring to 20. It's referring to 2020. People were concerned about giving immunizations rather than checking the quality of the data. How do we know the new people were found were really new and not old people?
Yeah, well, that's a really good question because also I try to recall how my ethnicity data was collected when I got my first COVID shot because that is the source of this data. It was quite extensively questioned. Also, they forced me to fill out to complete my form. So I assume that is done by other people as well. They are registered as Pacific people, and I do not think it is very likely that people not of Pacific ethnicity would have ticked the Pacific box. So I think that would be an argument that it is likely correct, the Pacific ethnicity. If not, it's still underestimated.
Right. And George has asked in terms of how do we sort of present this kind of data when we're working in districts or nationally, what statements should we make about the quality accuracy of ethnicity data?
Yeah, a good example, I looked very much into also DHB reports previously, and Counties Manukau has flagged this for a long time, the problems with their data, and also commented on it. And I think also they have the biggest problem, of course, of inaccurate data. But I think that would be a good example how to comment on this.
Thank you. All right, let's move on. Corina, all yours now. Thank you.
Thank you. I'll just share my screen. Okay, and I'll put it on slideshow. Okay, just checking you can see the slides okay, and it's not the notes. Yes. Okay, that's great. Thank you. Tēnā koutou katoa, talofa lava, mālua lei, whakalofalahi atu, kia ora nā, Nisa Bulavanaka, and very warm Pacific greetings to you all. Thank you very much to Pam, Omia, and the college for the opportunity to present today. Also, thanks very much to Gerard for your awesome talk. But also thanks to everyone who has joined this webinar on a Friday afternoon. Really appreciate your time today. For those of you who don't know me, my name is Corina. I currently lead the Policy and Insights Directorate at the Ministry for Pacific Peoples. I'd also like to acknowledge my colleague, Dr. James Greenwell, who has done a lot of this work, and I'm so pleased to see him online so he can answer any questions. Look, as an epidemiologist, I realise that the topic of data quality, which I personally am extremely passionate about, can seem extremely dry and maybe even unnecessary to talk about. However, I hope the slides I present today stimulate some discussion around data equity and representativeness in data and the pressing need to make this fully transparent. So I'm really excited to present alongside Gerard and present some of the work that we've been doing relating to Pacific peoples and their representativeness in official statistics. So for those of you who aren't familiar with our work, the Ministry for Pacific Peoples is the Crown's principal advisor on policies and interventions aimed at improving outcomes for Pacific peoples in Aotearoa. Our ministry was the very first ministry to undergo a performance improvement review, which is now required of all government agencies. And our review was conducted in 2023, but published in May last year. So the review focused on organisational strengths and opportunities. And one of the recommendations that came out of the review was that we needed a data and insights function that could draw information across government and influence the collection of Pacific data to present an overall picture of system impacts and data quality for government stakeholders. Similarly, our long-term insights briefing, which was published in 2023, which is another report required of all government agencies to identify future trends and opportunities, was focused on improving Pacific data equity. And that briefing really helped to shape our data and insights work program and what our key focus areas should be. So, we all know how important and how powerful data is. And we hear a lot of talk in the health system and in other sectors about how important it is for the decisions we make to be data-driven and evidence-based. Government agencies are also very focused on the social investment approach, which is very dependent on good quality data to identify people who are at greatest need and who could benefit the most from specific interventions. So according to the Social Investment Agency, social investment is the consistent, rigorous, and systematic application of data and evidence to improve the impact of social sector spend. Now, in September last year, a cabinet circular was released to all agencies about ensuring that public services are based on need. And I've highlighted a couple of paragraphs here. So as a society and as a matter of responsible government, it's important that public services support all New Zealanders and particularly those who need them most. We need to ensure services are prioritised on the basis of need so we can maximise the impact of investment and improve people's lives. So we need to invest in specific population groups where there is evidence of persistent disparity in outcomes or opportunities between that group and the general population. So this really shows you how pivotal good quality data is in ensuring that we are able to identify those in greatest need. Now, many of the measures that we regularly report on in government come from what we call Tier 1 statistics. Now, Tier 1 statistics are referred to as New Zealand's most important official statistics, and there are currently 162 of them under the 7 categories listed here. They're produced by 16 different government agencies, including Stats New Zealand, and they're described as essential for understanding how well New Zealand is performing, critical to inform decisions made by government, businesses, and communities, important to be able to compare New Zealand internationally, and fundamental for ensuring we meet our international statistical obligations. And here are some examples of the statistics that are used in the categories that we as public health practitioners might be particularly interested in. So for example, under the population category, what the structure of the population is, the dynamics, what families and households look like and how they're structured. Obviously, health is really important to us, household living standards, housing, safety and security, and social cohesion. So what are the data sources for these Tier 1 most important official statistics? Well, Gerard's already mentioned the census and administrative data, but we also have government household surveys, which I'll talk about in a bit more detail later. But firstly, just to reiterate basically what Gerard has said about the census. So the census is so important because it's the only population-wide survey and it's conducted every 5 years so that we can count every single person and household in the population. Not only that, but it's our only comprehensive data source for some very specific measures. For example, iwi affiliation, smoking, religious affiliation, languages spoken, household structure and size, home ownership, and the list goes on. So I've drawn this graph here from figures that are publicly available from the latest, the 2023 census. So as Gerard already pointed out, census coverage rates, according to Stats New Zealand, has been increasing over consecutive censi in all population groups. But as Gerard pointed out, we need to exercise caution because that definition of what a coverage rate is has changed over time, and that was because of what happened in the 2018 census and the need to enumerate or count part of the population with admin data. Okay, so because of that unexpectedly low response rate in 2018, Stats New Zealand was forced to count those missing from the population by augmenting the census data with data from admin sources. So basically data that's collected by government, but for other reasons. So, you know, if you file a tax return or if you somehow touch the education or health system. So as you can see from this table, this so-called admin enumeration was unevenly distributed, with a much higher proportion of Māori and Pacific people being counted in the census through admin data. So what this means is that the data that we can only get from the census, like smoking, like household size or languages spoken, is missing for around 20%, that's 1 in 5 Māori and Pacific people. And this really impacts our ability to understand what some of the specific needs of our communities and populations are, and hampers our ability to make those data-driven and evidence-based decisions that we're expected to make. Okay then, so you might ask yourself, well, what about those government household surveys that we use for Tier 1 stats? Are they any better? So there are a number of household surveys and they're widely used across government for decision making. For example, they've been used for some of the measures in the Treasury Living Standards Framework and Te Whatu Ora's Health Status Report, and they're also frequently used in research. The 2008 National Nutrition Survey of Adults, for example, resulted in recommendations to use iodized salt in bread and to fortify certain foods with folic acid, both of which are now mandated through legislation. So our team set out to systematically examine the quality of data for Pacific people across the government household surveys. And our first finding was that despite being called household government surveys, the surveys aren't currently administered as a suite of surveys. So there's no one place you can go that will tell you the full gamut of household surveys that are conducted across government, what they measure, and how often they are undertaken. We chose 6 surveys to look at in depth, and they're presented in this table. So they include the General Social Survey, the Household Labour Force Survey, and the Household Economic Survey, all of which are administered by Stats New Zealand, the New Zealand Health Survey, which is administered by the Ministry of Health, the New Zealand Household Travel Survey, which is administered by the Ministry of Transport, and the New Zealand Crime and Victims Survey, which is administered by the Ministry of Justice. For each survey, we were interested in finding out how many people, or how people were recruited and how many Pacific people were included, and whether the sample sizes were adequate to detect differences in measures between Pacific people and other population groups. And what we found actually is that there are a number of ways that surveys are designed that inadvertently underselect Pacific people. So you will be aware that the regional distribution of Pacific people in New Zealand is very different to that of the total New Zealand population. We're really concentrated in specific geographic regions, including Auckland, where roughly 2/3 of the Pacific population lives in Aotearoa, 11% live in Wellington, and then there's 5% in Waikato and Canterbury. So all of the surveys use sampling units to try and ensure good coverage across the whole of New Zealand. Several surveys also use an urban-rural selection criteria, which is in the ratio of 1.35 to 1. However, this results in undersampling of Pacific peoples because over 90% of Pacific peoples live in major and large urban areas. Surveys also try to get a good range of people across the different deciles of NZDEP, but again, Pacific peoples tend to be concentrated in a small number of deciles. So we know that around, for example, 60% of Pacific peoples live in areas that are classified as decile 9 and 10. Most of the surveys also sample only one member of the household over the age of 15. Census data tells us that Pacific people are more likely to live in family, multi-family, or multi-generational households and are among the least likely to live in couple or one-person households. So with Pacific people being more likely to live in larger family groups, that means Pacific households actually occupy fewer dwellings relative to other groups, which can reduce the probability of selection. Most surveys also target those 15 years and older, but we know that the Pacific population is a lot younger than the total population, and approximately a third of the Pacific population is under the age of 15, compared to 19% of the total population. Some surveys, for example, the New Zealand Health Survey and the New Zealand Crime and Victims Survey, also oversample older people by targeting aged residential care facilities. However, this also disadvantages Pacific people because only 5% of Pacific people are aged 65 and over, and older people are also more likely to live with other family members rather than in aged residential care facilities. Response rates for many surveys is used as a primary measure of data quality, and response rate is basically the proportion of individuals or households who responded to the survey. A high response rate reduces the risk of non-response bias and means that survey results are more likely to be representative of the target population or subpopulation. But we found that 5 of the 6 surveys that we looked at didn't report response or coverage rates for Pacific people, so it was impossible for us to understand or assess representativeness or quality of data. 2 surveys, the General Social Survey and the New Zealand Crime and Victims Survey, reported the percentage of respondents that were Pacific, which I guess is something, but not terribly helpful. The New Zealand Crime and Victims Survey also at least published the number of respondents, 322 that were Pacific, but it's still a very small number. And it makes it very difficult to do anything meaningful in terms of a multivariate analysis, or speaking to Eseta's question previously, to look at differences by specific ethnic groups. Of all the surveys, you'll be pleased to know that the New Zealand Health Survey was the most transparent. They showed the number of Pacific children and adults who participated. They also published response and coverage rates. So this graph here shows the published coverage rates for the New Zealand Health Survey between 2018 and 2023. The coverage rate is an alternative measure related to response rate, and it basically measures the extent to which a population or subpopulation has been captured in a survey. It can also be interpreted as the extent to which a population is missing or did not have the chance of being selected in a sample. So as you can see from the graph, coverage rates are published for Māori, Pacific, and Asian people, and also separately for the total population, but surprisingly not for Europeans. So we can't actually make comparisons to the largest group that is sampled. Now, because there was no publicly available information to allow us to calculate coverage rates for the other household surveys, we actually submitted data requests to each responsible agency for the number of people by ethnicity who were included in the surveys between 2018 and 2023. We then used that data to calculate the coverage rates ourselves. So just like Gerard was talking about before, we could have used two different denominators. We could have used the traditional denominator, which is just census data, or the APC denominator, which is basically a combination of census data and admin data. Now, which denominator you use didn't actually make much of a difference for most population groups. As you can see, they're not much of a change, except for Pacific peoples, who are shown in light green. So if you use the census denominator, it results in much higher coverage rates than it does if you use both census and admin data. But in any case, whatever denominator you choose, survey coverage rates are lower for Pacific peoples and Māori compared to other ethnic groups. So there are inequities in the representativeness of the data. We then wanted to calculate what sample sizes would be needed to ensure we had enough power to detect the differences between populations and over time. And this slide also highlights the importance of really thinking through what your comparator group is. So we use the census indicators for damp housing and full-time employment. And then we compared these with survey counts for damp housing from the General Social Survey and the Household Labour Force Survey. So we estimated that for a survey sample to have enough power to detect a true difference between Māori and Pacific peoples, you would need a sample size of 2,094 for each group for the damp housing indicator. But if you wanted to detect a difference between Pacific and European peoples, you only needed a sample survey of 125. And that was because the difference in the indicator is so much bigger between Pacific and European people than it is for Pacific and Māori. This difference is even smaller when you're looking at full-time employment. We calculated that if you actually wanted to compare Pacific and Māori people for the full-time employment indicator, you would need almost over 72,000 people in each group, compared to only 1,300 if you were detecting differences between European and Pacific peoples. And this is important because you often see in government reports that people are comparing Pacific and Māori statistics, giving very little thought to whether these are actually statistically significant or not. So, based on this work, we came up with 3 very high-level recommendations, and obviously would be really interested in your thoughts on any other relevant actions. Firstly, we think that government household surveys should be run as part of a coordinated whole of government program. This would make it so much easier to access the results and look across the different surveys to identify which measures are relevant to the work we do. Government surveys should also share data quality requirements, including standards to ensure representativeness of all major population groups. As part of this coordination, all household surveys should report information on the quality of the data published. This includes the numbers of people that were approached and ultimately sampled, the response and coverage rates, including for all different groups of interest. And finally, obviously, household surveys need to find ways to increase the number of Pacific people selected and improve response rates. Now, this might sound like a really simple recommendation, but Pacific sample sizes, response rates, and coverage rates have not increased significantly over many years of these surveys, despite significant population growth among Pacific peoples during that period. Thank you very much, and I would like to acknowledge everyone that worked on this, including Gerard, James, and Debbie Ryan, who is also here. So, whaftai lava.
Thank you so much, Corina. Another excellent presentation, and also acknowledging Debbie Ryan on the Zoom call today. So do we have any questions from the audience? If you do, just your hand up or just unmute and speak. I have a comment from George. Corina, can you read it, or for those?
Thanks, George. It's good to see you online. For those working in districts or nationally, what statement should we make about the quality, accuracy of ethnicity data, and what action should we be taking when we ask for extracts from Health New Zealand? Yeah, that's a really great question, George. I think honestly, like when we get data, we just need to go back to basics and think about, okay, so how did people get into this data source in the first place? You know, was the opportunity to get into the data source equitable? If it wasn't, do we know what the inequities might be? We just need to know what some of the kind of strengths and limitations are, and exercise a bit of caution if we're going to be making any kind of conclusions. Often what we found is obviously the sample size is big enough to make conclusions about total population, about Europeans, but when you get down to some of the smaller groups, you probably need to do a bit more digging and figure out, okay, so how many people were actually included in the survey. There was, I think, the New Zealand Health Survey in 2021, maybe, was really impacted by the lockdown in Auckland, and because of COVID, which meant that because Pacific people are so concentrated in the Auckland region, we saw some real like real big differences between years. So in that case, because there weren't that many Pacific people in the survey, best not to make any conclusions, best to say actually the data is not of sufficient quality that we can actually make robust conclusions, and then wait for the next year. I hope that makes sense. Thanks, George.
Thank you. Corina, there's a comment from Megan regarding statistical significance versus practical. Do you have any comment to make on that?
Yes, thank you so much, Megan. I totally agree. Practical significance is important, but what we often see in the data is people will say, oh, you know, there was a difference of like 1 or 2% between Māori and Pacific people. I mean, that's silly. Like, that's basically the same. We would really love to see actually confidence intervals regularly reported in the data, because often you will just see a line, and people don't really understand actually that we're often just taking a sample, and you know, if you're a much smaller group, that variability is going to be a lot bigger. So you can make comments about trends over time, but you do actually have to exercise caution when you're making some conclusions. Right. Does Gerard or James or Debbie want to add anything?
Yes, I couldn't find the mute button. Yeah, additionally, I think also it shouldn't be left up to the users to do all these quality checks, because it's really important that that becomes centralized. And with the surveys themselves, and if they will become all centralized, as Corina suggested, I think those quality and also confidence intervals and response rates should be published with the surveys, so it's accessible for everyone, because uniformity is also really important in interpretation of data.
Debbie and James?
Nothing to add, just brilliant presentation. Thank you.
Awesome presentation, Corina.
Of all your work, everyone.
There's a comment from Zoo regarding, I would say just regarding the comparisons by ethnicity. Can someone respond to that? About using total response?
Yes. And we're currently having these conversations, and they're increasingly important. So just to kind of recap, we in the health sector, we often use prioritized ethnicity, which prioritizes people into one ethnic group in the order of Māori, Pacific, Asian. But we also use total response, which means that, say, someone like me, I'm Samoan and European, gets put into 2 groups. And that's increasingly important from a Pacific point of view, because 40% of Pacific peoples identify with another ethnic group. And as Gerard said, more than 1 in 5 Pacific peoples also identify as Māori. So it's important to capture that. What's tricky with total response, though, is that you don't have a nice a denominator that adds up to 100%. So you have to do a bit more kind of mental gymnastics when you're comparing between groups. But what you can do is have a mutually exclusive comparator group. So what we often do is have Māori, Pacific, Asian, and then a non-Māori, non-Pacific, non-Asian comparator group. Thanks, Lafon. Great to see you.
George. Oh, George has a comment. All yours, George.
Thanks, Corina. Great presentation. I just wanted to follow up with the comment that you made about confidence intervals should be reported. I pasted a link to some health target reporting for the last quarter. Should we ask for confidence intervals on that?
Oh, good question. Gerard or James or Debbie, do you have thoughts about that?
Or if it's, because it's everyone, do we still need to?
Sorry, I'm just looking at a link. I think wherever possible, I always really like confidence intervals. I can't see this quickly how possible it is for this data set.
We'll get back to you, George.
Yeah. I would say yes. We come back to you if it's no.
There's a question from Janine Ryland. Te Whatu Ora's best available population. Would you like to respond to that? If we're not using it for monitoring, what source should we use to monitor equity of access, treatment, outcome by ethnicity in health districts?
Yeah, that is a very overarching question. It is used for monitoring because we don't have a better alternative. So we just all veer to this denominator because there's nothing better. And then it got so implemented that we do not remember the shortcomings either, even though it is warned on the website all the time. I think our recommendation, making a population backbone, like some countries, many countries have a population register, that would be the ideal. We now have the PHO enrollment real-time data, which has 95% of the people in it. You could do the same for a whole population, also not enrolled, and then improve the quality of the data. But I do not think there is political or statistical willingness to do that, but that would be the most solid solution, in my opinion.
Wonderful. I think we don't have any more. Oh, there's Megan. Target data isn't a survey, so there is no sound. No, oh. It's sorry, this thing is jumping a bit. There's a comment from Megan. Any response to that about the target data? All the error is non-sampling error, which usually can't be measured. Anyone? Corina or Gerard?
I mean, like great points. I guess even when we're thinking about the target data, you need to go just back to basics and go, okay, so how do people get into the data sets? So for example, I know that there was some talk when they were looking at the immunisation health target about what denominator to use. Like, do we use as the denominator everyone who's potentially eligible for an immunisation, or do we use people, or do we take out the people who have actively decided that they're not going to be immunised and then just use that as the denominator? So like all of this is really helpful, and I guess I don't have the answers for that, but it's just we need to make good decisions by going back to basics and thinking, do we have the right people in the data set? You know, what are some of the inequities for getting into the data set? And does the denominator actually make sense?
noting Michael Chang's comments as well.
And thanks
right.
everyone for all your lovely comments. It's great to see everyone on a Friday afternoon.
It is wonderful. Well, I think we've come to the end of this presentation. I must acknowledge the college as well for the initiative, Corina, yourself as well, as part of the college, and Gerard as well. So thank you very much, everyone, for joining us today. This meeting has been recorded and will be available to fellows. For those that are not part of the college, New Zealand College of Public Health, please get in contact with Pam or myself, and we can assist you should you wish to listen to the recording at a later date. Thank you very much, everyone. Have a great weekend. Ka kite.